So today I'm going to speak about the fungal infections of skin. So the pathogens of skin can be separated into two groups: those that cause superficial infections and those that cause deep infections. The superficial fungal pathogens, they are confined to the stratum corneum and they are caused primarily by dermatophytes, whereas the deep fungal infections of the skin, they involve the dermis and the subcutaneous tissue. And the third group, which is the systemic, they only involve the skin secondarily. So first we'll speak about the superficial fungal infections. Okay, so as we said, it infects the stratum corneum and it's mainly infected by dermatophytes, and the infection is called dermatophytosis, and they infect the non-viable keratinized epithelium. Okay, and they mainly affect the non-viable keratinized epithelium of the skin, mucous membrane, hair, and nails. And these dermatophytes, they synthesize keratinase. That's a protease that will digest the keratin and nourish them. Okay, and so these organisms can grow in soil and on animals. So a change in the skin microenvironment usually causes the superficial fungal infections. So this allows you overgrowth. Now there are three types of this superficial fungal infection by dermatophytes. One is epidermal phyton, the second one is the microspora, and third one is a trichophyton. The trichophyton species is that the most common is Trichophyton rubrum, and that causes the tinea or the ringworm. Okay, and so they have distinctive clinical features depending upon the site of infection. If it involves the scalp, it is called as tinea capitis. If it involves the beard, okay, its beard area, it is called as a tinea barbarae, usually seen in adult men. And then if it involves the trunk, legs, arms, or neck, it's called as tinea corporis. If it involves a face, it is called as tinea facial. And if it involves the trunk and all, it's called as tinea corporis. And it is a common superficial fungal infection seen in all ages, particularly in children. If it involves the hands, it is called as tinea manis. If it involves the feet, it is called as tinea pedis, also called as athlete's foot. If it involves the groin area, it's called as tinea cruris. If it involves the nails, it is called as onychomycosis. It's called as tinea unguium. Okay. So, depending upon the site of involvement, they have different names. So we saw the pathogenesis of how the dermatophytes, they infect the non-viable keratinized epithelium. They synthesize keratinase, they digest the keratin and nourish these organisms. And next we'll speak about the lab diagnosis. Okay, so how can we diagnose this? We can diagnose this by microscopy. Microscopy will show variable appearance, depends upon the property of the organism, host response, and the degree of bacterial superinfection. It can vary from mild eczematous dermatitis associated with intradermal neutrophils. Okay, so we can also use some special stains like PAS stain and the GMS stain. So the special stains are a periodic acid shift stain. Okay, so this stains the cell wall of the fungi, because the cell wall of the fungi, it is rich in mucopolysaccharide. Okay, so the fungi stain bright pink to red with PAS stain, and they are found in the anucleate cornified layer of the skin, hair, or nails. Okay, so bright pink to red color with PAS stain, periodic acid shift stain. And the other stain is GMS, that is a Burkhardt methylamine silver stain, and IHC with antimicrobacterium bovis antibody, also called as the BCG antibody. Okay, so these are the special stains, IHC. Then we can also do culture. Okay, so the material scraped from these areas on culture, they show the species. Okay, then coming to tinea capitis. In tinea capitis, what we can see is the hair follicle. The hair follicle is infiltrated by inflammatory cells, and focally destroyed. Okay, so there will be hair follicle will be infiltrated by inflammatory cells, it will be destroyed and it will produce an abscess. Okay, and the perifollicular area also shows a dense mixed inflammatory infiltrate of neutrophils, eosinophils, and plasma cells. And also the fungal hyphae can be seen in and around the hair shaft and occasionally in the interfollicular cornified layer. So these are the findings we can see in Tinea capitis. Next, coming to Tinea corporis. Tinea corporis, the epidermis will show mild acanthosis, focal spongiosis, and parakeratosis. And the cornified layer show exocytosis of neutrophils and small collections of neutrophils. And also you can see fungal hyphae in the cornified layer, especially in the layer between the orthokeratosis and parakeratosis. And the superficial dermis also shows perivascular lymphocytic infiltrate and occasional neutrophils and eosinophils. So the differential diagnosis we should keep in mind are acute and subacute dermatitis, psoriasis, impetigo, folliculitis, and all. So now we saw about the superficial skin infection caused by dermatophytes, mainly the trichophyton. Okay, so there can be other superficial fungal infections also. Okay, like the Tinea versicolor and the Candidiasis. Okay, Tinea versicolor, it is caused by Malassezia furfur, and that's a yeast. Okay, and it is not a dermatophyte. And this Malassezia furfur needs a moist, lipid-rich environment. It is most commonly in young adults, okay, where there is excessive production of sebum. It develops on the upper trunk, and it has a distinctive gross appearance of macules. Next, Candidiasis. It's caused by Candida species seen on moist. Here, microscopically, also you can see hyperkeratosis, epidermal hyperplasia, chronic lymphocytic infiltration. Past, you can see the budding and the hyphaeal forms. Okay, it's mostly seen as superficial layers. So this was about the superficial fungal infections of the skin. Okay, so next we will go to the deep fungal infections of the skin. Most systemic fungal infections develop in the lungs due to inhalation of aerosolized material which are contaminated with organisms, okay, mainly like histoplasma and blastomyces. So primary lung infection, they may disseminate and they may spread to the skin or the mucosa. And an underlying immunocompromised state will increase the risk of dissemination of fungal organism. So locally invasive fungal infections of the skin are rare. Okay. So next we will speak about the subcutaneous mycosis. There is first chromoblastomycosis, then mycetoma, and then sporotrichosis. Okay, and also there is pheohyphomycosis. So first we will speak about the chromoblastomycosis. Chromoblastomycosis is also known as the chromomycosis. Okay, so it's an indolent chronic skin infection of the subcutaneous tissue, and that is characterized by nodular verrucous or plaque-like painless lesion. Okay, so they usually begin as papules, and over the years they become verrucous, crusted, and sometimes even they become ulcerated. So these lesions, they predominantly develop on the lower extremities, okay, and they grow over months to years, and they can be caused by several species of fungi that leave as saprophytes in the soil. So the fungi are brown, round, thick walled, and measure 8 micrometer across, and they have been likened to the copper pennies. Okay, so these infection is most common in barefooted agricultural workers in the tropics. Okay, and the fungus is inoculated by trauma, usually below the knee, and the infection spread by contagious growth and through lymphatics. So eventually it may involve the entire limb, and there is usually no extension of infection to adjacent structures. Okay, long-term complications can involve bacterial superinfection, chronic lymphedema, and development of SCC. So this is a pathogenesis. It's mainly seen in barefooted agricultural workers. It spreads by lymphatics. So this is about the chromoblastomycosis. So in pheohyphomycosis, any infection with a pigmented mold, it's called as pheohyphomycosis. So in that there is chromoblastomycosis and mycetoma. Okay, so next we will speak about the mycetoma. So mycetoma is also a chronic suppurative infection involving the limb, shoulder, or other tissues, and it is characterized by draining or discharging sinus. The discharging grains or material consist of colonies of fungi or bacteria. Okay, so the types, there are two types, okay, depending upon the causative agents. One is eumycetoma, that is a fungal disease, and actinomycetoma, that is a higher bacterial disease. Okay, so the fungal causing eumycetoma include both hyaline molds and by brown black molds. Okay, so eumycetoma is a true fungal, okay, caused by Madurella mycetomatis. So the organisms are inoculated directly from soil into bare food during agriculture work, okay, or from contaminated sacs on the shoulder into the hands from infected vegetation. So morphology, it involves the skin and subcutaneous tissue. So after several months of infection, the affected site, mostly the foot, manifests as open pore, okay, or break. The affected area is swollen, and when the foot is affected, it is called as Madura foot, and it spreads along the subcutaneous tissue, along the fascia, and eventually it can involve the bones. And they drain serosanguinous fluid containing granules through the sinus tract. Okay, so this was about mycetoma. And the size, color, and degree of hardness of granules depends upon the etiological species and and are characteristic of mycetoma. The surrounding tissue can show a granulomatous reaction, and the fungus usually stain positive with GMS stain. Whereas actinomycetoma, it is a bacteria, anaerobic bacteria. So next we will speak about sporotrichosis. Sporotrichosis is caused by a dimorphic fungi. It is called as Sporothrix schenkii. It's a thermally dimorphic fungi. Okay, and it is found in the non-flowering plants, decaying vegetation, soil. Okay, and the mode of infection is by accidental inoculation of the fungus from thorns, especially rose thorns or splinters, or by those handling reeds or grasses. Okay, it mainly affects those involved in outdoor activities such as landscaping, gardening, and all. So pathogenesis by inoculation of this fungus, it enters into the skin and proliferates locally. That will result in an inflammatory response at that site, and it will produce an ulceronodular lesion. And it spreads usually along the subcutaneous lymphatic channel and results in a chain of similar nodular lesions. Extracutaneous disease, joint and bone involvement is usually less common. And morphology, the lesions usually develop in the dermis or in the subcutaneous plane. Okay, and the periphery of the nodules of the ulceronodular lesion show granulomatous reaction, and the center show the separation. The epithelium surrounding skin shows pseudoepitheliomatous hyperplasia. Okay, in some yeast are surrounded by an eosinophilic spiculated zone, and they're called as asteroid bodies, and they probably represent the antigen antibody complex. Next, coming to the lab diagnosis. So first specimen collection, then conventional microbiological methods, then histopathological methods, immunological, molecular, and biochemical. So specimen collection from the affected site. So it depends. Superficial mycosis, skin scraping, infected hair, nails, mucosal scraping, or swab. Whereas in subcutaneous mycosis, pus, discharge, crust, biopsy, and swabs from the lesion. And if it is systemic involvement, then sputum, urine, pus, feces, CSF, blood biopsy. Okay, so this is how we can collect specimen. Now, next, coming to conventional microbiological methods. So, first there is direct microscopy. In a microbiological method, first is direct microscopy by gram stain, Giemsa stain, and calcofluor. White stains also can be used. And you can also do culture, but culture will take time. So, certain fungus can be detected by microscopy because of its distinctive morphology. Okay, so the stains which we can use are gram stain, Giemsa stain, and calcofluor. Okay, so gram stain is a commonly performed. It stains most yeast and hyphal elements. Most fungi stain gram positive, but some like Cryptococcus neoformans, they'll show stippling, okay, or appear gram negative. So mostly they are gram positive. Okay. Then Giemsa stain we can use. It's used in the examination of bone marrow, peripheral blood smear. Okay, and so here we can see intracellular histoplasma capsulatum, intracellular yeast forms of histoplasma capsulatum, and also you can see trophic forms of pneumocystic gyrovacuum. And that was about the Giemsa. Then calcofluor is for also detecting all fungi in fluid specimens. It detects the cell wall. It's rapid 1 to 2 minutes. Okay. So coupled with fluorescent microscopy, it will appear bright. Okay. But it needs fluorescent microscope. Histopathological methods, by light microscopy, we can use routine stains and special stains. Special stains like GMS, PAS, okay, musicarmine. GMS, it will stain the hyphae and yeast forms black, okay. So in GMS, against green background, okay, the fungal elements are stained black. It's used for screening purpose and to demonstrate actinomycin. Then music carmine, it's used for demonstrating mucin, a capsular material of Cryptococcus neoformans. Okay, it's a histological stain for mucin. And then PAS stain. PAS stain is a histological stain for fungi. It stains both yeast and fungal in tissue. Okay, so these are the special stains in light microscopy. Then you can also use direct immunofluorescence and in situ hybridization. Okay, so PAS will stain the polysaccharide in fungi. It will give a magenta color. You can also use immunological or serological methods like determination of antibody or antigen titers in serum for the diagnosis of fungal infection. Okay, we can use ELISA, complement fixation test, immunofluorescence, immunodiffusion. So these are different immunological tests. There are molecular methods like direct detection, identification by PCR. Okay, so then last there is a biochemical method that will detect the fungal metabolites. Okay, it will also detect the cell wall components and enzymes. Okay, so these are the different lab diagnosis tests we can do. In biochemical methods, we can detect the fungal metabolites. Okay, so the detection of fungal metabolites in serum or body fluids. Okay, so for example, detection of a D-arabinitol in serum, it indicates hematogenously disseminated candidiasis. Okay, and then the detection of elevated levels of D-mannitol in bronchoalveolar lavage fluid, it's used in the diagnosis of pulmonary aspergillosis. Okay. So these are the different metabolic tests we can do. So coming to a quick summary, so the fungal infections we said superficial and deep. The superficial fungal infections mainly are dermatophytes, as we said. The others are tinea versicolor and candidiasis. And dermatophytes, we said the pathogenesis, it involves infects a non-viable keratinized epithelium. It's incised keratinase that will digest a keratin, then trichophytin, the different types of tinea, we said tinea capitis, the follicular and perifollicular inflammation, then tinea corporis, the histological findings. Then we can use special stains like PAS and GMS, and also we can do IHC. Then we told about the deep infections and the subcutaneous. The subcutaneous infections are the pheohyphomycosis, and pheohyphomycosis, any infection with pigmented mold having melanin. The main pathogenesis is direct inoculation. First is chromoblastomycosis, also known as chromomycosis, copper bodies. Then we said about mycetoma, mycetoma, Madurella mycetoma. Then we told about sporotrichosis, the dimorphic fungi forming the ulceral nodular lesion, Sporothrixincae. Okay, and then we told about the lab diagnosis. Lab diagnosis, specimen collection, superficial, subcutaneous, or systemic involvement, depending on that. Then microbiological methods, we told by direct microscopical examination. Stains, we told about the Grams, Giemsa, calcofluor with immunofluorescence, and histopathologically light microscopy. H&D, then special stains like GMS, mucicarmine, PAS stain. We can also use Fontana Mason stain for melanin pigment.